sponsored by the Initiative for the Performance of Primary Healthcare, PHCPI of the World Bank, and Salud Derecho. I am Luis Gabriel Bernarda. I am a member of the facilitating team and the World Bank, and I'm a professor of medicine and sciences in Rosario University here in Bogota. I would like to welcome you here to all of you who are connected from the different places in Colombia and other countries in Latin America. We have now the simultaneous translation service to which you can have through the icon at the bottom bar where you can select the body of the language of preference. If not, the webinar is also being retransmitted directly in the YouTube channel of Salud Derecho. This session, this we have here, and then we have Salud Derecho. I would like to have the webinars. It's part of the activities that we have developed here within the framework of the practice of innovative models that we have been doing in the country, in which we have invited key leaders and other ones interested so that they register, having access here to the webpage www.saludderecho.net, where you will find information about events, publications, technical resources about primary health care, as well as learnings generated as of these series of webinars. Also, you will find the recording of them and the presentations of the guest speakers. In the chat, the Zoom chat of this webinar, you will find the link of Salud Derecho and a very brief video as to how to register yourself. In the past webinar, we had experiences that were very interested, oriented to preventive and adequate control and follow-up of the main chronic diseases that are not transmissible in the Valle del Cauca, Chocó, and Cundinamarca. At that time, we had the presentation of an initiative with the Secretary of Education of the Valle del Cauca province, the Chocó University, and the Health Manager Insurance EPS. And then we had also a presentation from John Hopkins of the expenses in Latin America associated with the burden of chronic disease required. In today's webinar, we will be focused in the innovations that from the primary healthcare, they enable you to have a prevention and control of the infecto-contagious diseases, a very relevant topic at the times where infectious diseases that are emerging and re-emerging have been testing the capacity of the response and capability of the players of the health sector and other sectors to reduce the impact on people and their repercussions in the sustainability of their system. The worrisome decrease in the prior years in coverage in terms of vaccinations and immunizations of the infected contagious diseases put at greater risk the most vulnerable peoples. The deployment of new strategies of surveillance of public health, as well as greater access to technology and prevention, diagnosis, and treatment of these type of illnesses from the primary healthcare is constituted, therefore, as the primary cornerstone to change the natural course of these infectious contagious diseases that is more prevalent. Before we start with our guest speakers, I would like to remind you that the mics will be deactivated until the final panel, time in which we will open the mics and you can raise your hand and participate. From now, you can pose your questions and comment at the Zoom chat. Initially, I would hand over the mic to Dr. Marta Espina, Director General of the National Health Institute for more than 7 years, who will speak about the new surveillance of public health for infectious contagious diseases, the lessons of the pandemics, the APS in action. Dr. Espina is a medical doctor, and she's studying her doctorate in public health, and she's a specialist in managed public health, a magister in epidemiology and economy of health, and an epidemiologist in this field, and they have more than 25 years of experience in the health sector. She has worked in several positions in the public and private sectors, aside from being a university professor for more than 25 years. She was a leader of the High Cost of Health, and Director of Health and Social Protection and Vice Minister of Health of Colombia. Dr. Marta, the floor is all yours. Hi, good afternoon to all, and thank you very much. I will share my presentation on the screen. If you could help me with that directly, you could share your screen from there if you so like. Perfect. Can you see my screen? Yes. Right. So to speak of public health for infectious contagious diseases, it's necessary to speak about the international protocols. And before the pandemic, many people had never heard about the PSI, but I am going to give you a brief presentation of what it is. Since the WHO meeting of 1951, there was already a document that spoke basically of having an agreement to carry out certain activities, especially in the ports where we had commerce amongst countries, in order to control some disease. And there from 1951, we started that and began to update the document. And it begins to speak the entire document to six illnesses. And it speaks that all countries that belong to the UN have to perform a whole set of actions so that these six illnesses would not be transmitted throughout the country or maybe eradicated by vaccines, or so that they don't get transferred from one country to the next. In the year 1973 and 1981, that memorandum was reviewed, and then they agreed to three illnesses. But something happened that was very important in 1995. Now, clearly, there was abundant travel, commerce, and epidemiology began to evidence the importance of the transmission chains that there were, because there was already like an extended commerce and a great possibility of moving from one side of the globe to the next. So they requested the review, the international review. So this norm in 2005, which is the one that we know now, and it's the one that is current today, up until the pandemic, basically, it's still there. It's just that now it has an amendment, but it's still current. And that norm was adopted in the Assembly 1958, of the 58th Assembly, because now it's very important, because it's speaking of the capabilities, to have capability. And it speaks as to how, what we should do to avoid these infectious contagious diseases throughout the country. And then it speaks about the capabilities that are binding for all countries. That compulsory document for all countries, we must understand it within the country, in the same way that the world expects that each country develops its capability, because at the end of the day, all of us are just as weak as the weakest link when we speak of countries. So within the Colombia, the same. We in Colombia are just as weak as the weakest province that we have, the weakest capability. And then all municipalities within that province are as weak as the weakest municipality. So that's why we must achieve and maintain basic capabilities. Excuse me, interrupted. I think that we're seeing the presentation frozen. Or are you frozen? No, I was in one of capabilities. You're not seeing it? We're seeing the first slides still. Yes, I'll check and see.
Está en modo presentación, la pueden visualizar en los dos lados
Now
igual.
you can visualize it
Está
on
en modo
both sides the
presentación al
same,
mismo
because
tiempo.
before it wasn't there in the presentation and you were seeing the notes.
¿La ven ahí? ¿Modo presentación? No.
No, no, señora, la vemos con las notas.
We're seeing it with the notes. We're not seeing it as a presentation, madam. Just simply there's you have the configuration of the presentation and you have to put it in presentation. Yes, yes. Right, that's how it is. But I
Es
mean,
que tienen doble pantalla, entonces si
you
quiere
have a
ponerlo
double screen. So if you want,
poner la pantalla. Sí, yo la tengo
Juliet,
chiquitica.
Juliet, if you want, you project it and we switch it. How's that, Juliet?
Ahora sí está perfecto.
Right, now it's perfect. Yes, fantastic. Okay, so yes, now it's passing, right. So we're going to retake. So we now know that we're in the norms of 2005 that speaks of capability. And those capabilities actually to recover the times the capabilities summarized or packaged are five. A country or a province or a municipality has to have capabilities to monitor, identify that something abnormal is happening. And something abnormal means that the behavior, the epidemiological behavior of such an event is not what it used to be, or as a matter of fact, that we're speaking of emergency, that they're coming here for something that we've never seen before. They have to have that capacity. A second capacity is to be able to diagnose. You must be able to identify that event. What is it talking about? The third capability is one to be able to answer to that event. And to be able to respond is to be able to recognize. And once you recognize, to know what the protocol is to react because of the nature of the event. What? Avoiding what? Avoiding the propagation or mitigating the propagation. The fourth capability that a country, province, or municipality must have is to gather the information, organize the information, analyze the information, interpret the information, and disseminate the information so that you can do specific things depending to the role. And the fifth capability is to be able to communicate, to broadcast that something is happening and to be able to broadcast it to different points. This, what I'm telling you, is not new. We know it. We have spoken it. We have mentioned it in many conferences of all types, and this is what we're trying to do internationally. But since in this webinar, what we're talking about is what is new and what happened. Well, at the front, I spoke that there are many lessons learned. There are many important lessons between the national institutes and amongst countries. One is here, and then the other one's in Panama. Now we're going to have one in Mexico. And they're where all of us, every country, high income countries, middle income countries, and low income countries, they all were badly assessed from this COVID pandemic and with very important lessons learned that we must make adjustments. So here we can see in this slide, yes, it did pass. Yes, yes, we did see it.
Ok. Aquí vemos esas mismas
So
capacidades.
here we can see the very same capabilities that I'm just showing you, but now I'm going to tell you what is new, what you're seeing here on the left. But it turns out that the world of monitoring and finding something abnormal, now we know that the IPSs of high complexity, the ones that have a capability, that have a natural capacity, that it was being wasted. Those institutions that provide healthcare had this latent capability that was was not properly exploited. So we have seen through COVID-19 before December of 2019, for example, there and they went there that if those units of purchasing power had patients would have been able, if they had done their task of isolating respectively those viruses in China of those patients instead of just doing the adequate response, the clinical response, but they would have done the containment, they would have done there. So the diagnosis capacity that they had there, it is the first line of defense that any country to find out. Before you have a pandemic or anything, we could, there's, and we have learned it, and we have been told many times. I mean, I was talking about this, the spillovers, and then we didn't have that spillover translation. Now we do say rebosamiento for spillovers, and they identify the deviation from a standard and in excess of case, an overflow, a spillover, and then they reacted immediately to. That's why it's so important for us to understand that any patient that have an ICU must have a diagnosis, must have a diagnosis. It is there. We can't have a patient without a diagnosis. A patient that it does not have a diagnosis has not been fully studied, and that's why those isolations will be so important. That's why you have this chain of labs to provide support to those ICUs, and then we understand that we must do re-engineering to the labs that do surveillance on health. These labs, when I'm talking about the provincial labs and then the reference labs that we have, so what they were expected, they waited massively to come the information from the territories. The one that arrived, it turns out no, the labs must have two peoples, two two employees before they work, engineers, systems engineers that use data and not record, but data engineers of all types, but also who can sample in probabilistic in the national territory. So that way, it is the lab that ensures that they have representative samples and to see how it's behaving, the spread. So many of the events that actually came there with wise surveillance and came to samples, now we're going backwards. That lab must go and look at the data, early warning systems through data analysis. And that's the big change. So the epidemiological human surveillance, but based on animal oversight. That lesson is really important for Colombia. We don't have a national animal authority. We have the ICA, which is for farming bears, and we have the Ministry of the Environment for wildlife. But we don't have, for example, of the other plants, those development, those authorities, and mascots. Who's controlling our pets? That's much easier because how can we contain an epidemic in animals and in humans? So therefore, the surveillance of animal diseases must be a part of early warning system that allows an intervention of the world animal before they make the jump to human diseases, but has to be integrated. It has to be domestic animals, production animals, and then we have humans. So that's the true integrated work of the three focuses of wildlife, pets, and then those for production for human consumption and so on. And what's the fourth lecture? To broaden the type of notifiers. Now we have actually forgot from the head of the work of what we had of community surveillance. All the no, no, we are out of there. So of course, that's important, but that changed. What do you mean? The world today, if you think that we have to broaden as to who we communicate to, many protocols that we have seen here, and we have seen here broaden that today, anyone is a notifier. Anyone hears. Before I was talking there with genetics, they go, I have a genetics lab somewhere. I have a private um, me- medical practice and so on. And I go to the institute and they will have there, and I could just type it up and notify them by being a doctor. And if I'm not certain, I could issue an alert. And then we have the paths of how we channel it and there. But now anyone can notify anywhere. I am a community leader. I am a doctor. I am a nurse. I am a mother in a school. I am a dean in a school. Anyone can go to the public health page and issue an alert. And that way we can do there. And we have a great basis messages, alert, and news warning that enables us to broaden the base of notification. Now it's not to find the case and confirm it through Laravel. We changed it, and we have the great volumes of news. Substitute the great volume from the great volume of data, substitute the lack of individual accuracy of the labs. And in the next capability in diagnosis, there's a great change. We saw it in COVID, and we saw it and we did it in Colombia with great success. We had a capability of doing 60,000 PCR. So 600 to 60,000 a day, 6 months later, to replace the diagnosing technique by molecular techniques. The molecular techniques came here, and we're never going to go back. Keep that in mind, all our molecular techniques. Broaden the network of molecular labs as a public-private strategy. They will continue to exist, public and private. You have a provincial lab, and we're saying, okay, you have to have three networks. The public, private, ready, yes, sure, awaiting in the event of emergency. What do you need? Hetero, hemorrhage, private theirs, or symptomatics, and respiratory ones. So the three big sort of major threat worlds, so to speak. So now we have to have allied networks updated to make sure that in the event of something, if you have to the first ring, the second ring, or the third ring, and you can increase in diagnosis capacity at the speed that the events needed. Third, you need to have metagenomics. Metagenomics already exist amongst us. So now to do a diagnosis blind, I say so there's if you don't know it, you don't there's but the metagenomics change it. There's look, you can't even think it, but you have to be able to diagnose it because you have to be able to extract it from the samples, reconstruct a genome, and then to say send it to a world database and find out what was it. And that's how we have to do the diagnosis. In the third capability, where we have to avoid propagation, we have to broaden human talent in epidemiology, field, and frontline. We have 137 of them. Now we have new ones that are actually graduated, just too few. You need 1,400 in the field. But now that has to exist if their post, if their hiring is assured. So therefore, it's important that the territorial institution modify their um, organizational chart and hire these people. So the plants, the org charts, they have to ensure of human talent so that they can have the necessary ones. You don't know what it can be to have a COVID-19 in March, understanding that the 1st of January, everything had changed. There was not one person there that we had trained to do the battle that we had to do to diagnose COVID-19. So we didn't have enough human resource trained. Also, that you have a risk analysis rooms that are permanent that are doing the analysis all the time. It's not there a relief group and so on. No, no, no. You have the analysis, and they realize of what the words are. But you have to have uh, operation emergency operations centers, COE for in Spanish, in their territory. So they have to bring all the information from everywhere, and in that way, they have to be able to build to construct their own conclusions as early warnings. And you have to broaden and stabilize human resource at the Secretary of Health so that you have human resource teams for immediate response initiatives, ERIs. So you have to be there on shift 7 by 24, not only nationally. We as an institute, we have more than 100 teams of that because we are 8 hours anywhere in the national territory. But the concurrence doesn't replace the fact that we can go from the central to the provinces doesn't mean that the provinces don't have to have their own response teams. So here, that is the true philosophy of the APS. On issues of gathering, organizing, analyzing, and disseminating information, what we knew, issuing bulletins, and so that's fine and good. Old bulletins, now they're having a page so that we know that there are people that actually are unable to read more than 130 characters. So we're reducing it to news, to headlines. So now we have to have there the headlines summarized. But the code, as you saw it in COVID, we had the dashboards that were used by public people, boards that anyone can actually come there. You can have graphs, curves, etc. And aside from there, in open data, actually make it downloadable. So it's the best way to match them and bring in all those experts. And then you have statistics you could have there. And then they give faith of the history. They're published forever and the picture of what's happening at that time. And then finally, on the issue of communication, and with that, I will finish my intervention. We all know about the risk communication. We have to have a spokesperson. We have to know what the progress is, but all countries, without an exception, and in China, and we actually saw the Health Organization of the World, of the continent, and like, we said, okay, what we lived was an avalanche of experts, of pundits, of influencers with massive messages, with walls speaking of the pandemic in social networks. And that is actually our main communication focus. How do you classify according to the origin of the type of messages and if they're relevant, if they're actually an influencer, if they can be harmful to our people, and what sort of different treatment should we be doing for these type of messages? This mitigates a part of the response or helps so that the social ones are aligned with what we need to do. And at the same time, you may achieve with them if we have alliance with them. They actually help us precisely to motivate the behavior which are fundamental in infectious contagious diseases. Because if there's no possible action without the help of the community, when we're speaking of a propagation diseases, transmissible diseases, human transmission, that would be um, the great summary. And I hope and I await the panel to answer any clarifications if my presentation has not been clear or if there are some questions. Thank you. Thank you very much, all of you. Dr. Mata, thank you very much. Very clear your presentation. And I would like to highlight what you have said as to how to pass from that reactive one to a proactive one, where aside from that, we have integrated one from different sources where we have public and private ones that are actually very important. From the labs capabilities in the territory, and we require intersectorial focus for this surveillance, where we all notify, we all do, we're not reserved to any particular institution, and the importance of organizing and distributing and training human talent that is uh, really capable of doing this in the field. And then if you have there to report, and if we could visualize this information by the main players and the decision makers and the internal managers of the networks, there's all relative issues that Dr. Marta has actually placed in this presentation and this mechanism of surveillance from the primary health care. Once again, Dr. Marta, I'm going to hand over the mic to Carlos Alvarez. Dr. Alvarez, welcome here. He's a medical infectiologist, a PhD in clinical medicine and doctor in biology. He's a honorary doctor of the American Society of Infectious Diseases, and he's currently vice president of the Colsanics Clinics and the studies of COVID-19 of the WHO, and he is actually illustrated in methods of prevention, diagnosis, and treatments of infectious contagious diseases from primary health care. It is a pleasure to have you here in this webinar. The floor is yours, Doc. Good afternoon. It is a pleasure to be here with you and to share this scenario with you and with Dr. Marta and Dr. Karaski and the other guest speakers that are all invited. I would like to for us to progress in my presentation. We're going to go very much hand in hand of what the doctor was mentioning prior to me. Specifically, I'm going to concentrate on the diagnosis in the seminar, the component of the immune uh, contagious diseases and what we're working on vaccines so that one way we can have a different means of what we usually do. In this first component, something that is unequivocally is the importance of what we have at this time to be able to diagnose. I think that it was mentioned by Dr. Marta in her presentation, the changes that we must have in the same focus of the diagnosis of infectious diseases. These transmissible diseases, for many years, we have seen that we've used traditional methods that definitively have helped in the evolution of mankind, but part of what must lead in these diagnoses is to have a timely diagnosis so that they can facilitate a quick diagnosis and they replace some of the methods of how we do it. I mean, so for example, if we have there's this publication in the CT of Europe of what is called the test at the point of care. So in other words, the patients don't have to go and come back to have those diagnoses, so they have to change from a first level hospital to a second level hospital, but actually from the doctor's office you can have there all the ones. So this is one of the response that we have for the different countries in the European Union. They have actually managed to replace some of the tests, the classical tests, with what they call the test in the point of care. And there we have the POCT for the transmission of sexual diseases they have here, where they have actually led, given the difficulties that many times we have, so that people actually go to the clinic once and you take advantage of there. And here we could see this slide that includes respiratory diseases, dengue, cholera, and probably here we don't have Caroqueria malaria, but obviously for the European community, but it's clear this is what we need here. And here we can see here in this same survey that we do at the POCT, why do you use these tests? And basically you see that some there's for the surveillance system, for the report, the national report of infectious diseases, and the surveillance ones for outbreaks, for infectious control, for monitoring infectious diseases, and for the very test of the diagnosis and other associated to the monitoring of the resistance. And we see here, when we talk of quick tests, we need to see the diagnosis in less than 1 hour, some in 10 minutes or less than 10 minutes, that definitively facilitate the timely diagnosis. So we can see that one of the problems here from the standpoint of public health of the infectious disease that is associated with One Health is the microbiology resistance. So one of the difficulties that we have here in this microbe resistance is not to have a diagnosis certain this or with good certainty that makes us the stimulation to the use of antimicrobials. And this is one of the traditional ones that we have in this chat. I like to make the awareness of the use of antimicrobes and how this timely diagnosis can facilitate the use of this antimicrobial. Here we have a microbiology, and here we have the use of the first primary healthcare, the pneumococcal, the different tests that you can see and read here. And here we're talking about the lateral flows, but actually the molecular techniques so that we can facilitate the diagnosis and quick tests that clearly with COVID-19 we were able to be able to see with this COP2 and how we could do it in a timely manner. Here we have a publication where you can see, it can show you how it is possible with COVID-19, the inclusions of antigen tests that actually reduces the times. But then we have other types of technologies, and we can speak of PCR or RPCR. It was something sophisticated, and now we have RC-PCR tests that easily can have at the point of care that's going to facilitate the response time and also the possibility of seeing this timely diagnosis. Here in this publication shows you that you can shorten the time when the patient meets the doctor, and then we can have that at time when the patient comes to the doctor at the doctor clinic in primary healthcare. They require a test. They can take, be transported into a lab to a greater level of care, and then we can have the molecular diagnosis called the culture test. But it's not something that actually proposed that you should not do culture. We're not saying that we don't have to do culture, but this was a strategy that in other cases we were used here in the panel. But I mean, here we can see that the doctor can do on the and the doctor's clinic, he can actually do and run quick tests, and there we can see there that in less 1 hour and less than 24 hours, even our territory, it can be more so in the territory. So, and then we have the molecular words of quick test, that the traditional method may take days. We could have a sensitivity that's low, to have low cost, and the molecular words can be relatively costly. But we talk of different ones, the molecular methods, they can actually be of low cost. Here is where we require greater strategy with the traditional methods that actually be there. And we can have it at the medium, and then very probably the traditional method that usually can be a microorganism, the molecular ones can actually find several in parallel. So then we can be the molecular methods actually could be high because of here one may propose in terms of the cost and the precision, what is the relative cost? Because many a times for when we speak of the introduction of these diagnostic methods and they say that they can increase the costs in the healthcare system many a times, what we're saying is when do you calculate the cost? Because sometimes not to have a proper diagnosis early in timing, that generates a very high cost because you don't know what the treatment and you have an inadequate treatment and actually could be more costly for the data, but it could be from the economic standpoint. And then we can actually leverage it. So we have in pneumonia, for example, once the patient comes there and you have a combination of combined therapy, according to the recommendation of what are the medical protocols, then we can see and we can initiate an antiviral and another antibiotic, and then we can give it to an individual. And according to that, by handling this directed management, they can have a quick escalation of antibiotics and a high use, especially when we have some viruses and we have antimicrobial resistance there, and we can have there less resistance. So therefore, this is a classical example by having quick, good diagnosis early at the beginning, even if it's of high cost, we know how to change our protocol or reaction. These are the different scenarios that we have here of the incidence, for example, of tuberculosis that we have been viewing for many years and promoting and teaching the use of the tests of what we have there, in spite of what we know that we have the different tests, but definitively the very recommendations that we have that are proposed from the World Health Organization, the need to use molecular tests for the initial diagnosis of tuberculosis. So this would seem for certain people an abrupt expense and so on, but definitively we begin to demystify the use of molecular tests, quick molecular tests for reference labs or third level of the hospital, but rather precisely, and we saw it. We had the opportunity of having Dr. Martin here, that we had the entire process of leveraging the molecular test in the different places of the Colombian territory. How is it possible so that we actually can have this built-in organism, as the cases that we have been shown in the new ways of the World Health Organization? We saw it last year, and also we can see this same scenario. What are the changes in paradigm for the molecular test in the case of the detection of the human papilloma virus detection there? And then we have an entire world of work that we need to do, and we need to continue to progress in this type of tests in diagnosis. Another scenario where we actually have to know what the epidemiologic agents are, and has to do the SARS-CoV-2 and the other respiratory diseases that at some given point in time actually can have six, seven viruses at the same time, where it is important for us, not only for this, the epidemiological surveillance, but actually for the clinical treatment and for the formulation of the patients so that they can have their primary care and to have a precocious diagnosis to know what the protocols to use. Here we see how clearly we begin to use tests with the possibility of having multiple diagnoses at the same time. We can detect the different microorganisms, be those microorganisms that are respiratory ones, or diarrhea ones, or central nervous systems that cause other clinical diagnosis that we have of these transmission ones. And then here, and then we have how what we have this is correct and it's adequate to the diagnosis that it's going to avoid with what we have in COVID-19, where we see that 3.5% of the patients actually had co-infection, but 71 of them had microbiotic antibiotic treatments. So definitively, there we have to see in the detail of the COVID-19. We actually can have there an excess use of this use actually increased the pandemic, and then we have there, and then we have the molecular there, and then we have the opportunity and enable this to know, and probably at that time where we have now of the epidemic ones, and this is what we have for therapy in ambulatory ones and so on for care. And then we have here to actually speak of what Colombia did for the amount of countries, and then we have for the possibility of having that combination in the different parts of the Colombian territory. Here, I would like to highlight in this slide what I just commented, the possibility that we have of the use in primary healthcare. And this is just for the diagnosis of sexual transmission, and then we have individual diagnosis or combined with phobia, ephedema, and so on that actually can facilitate how the protocol of treatment can have there. And here we can have the same recommendation with early tests that we have in importance, and we can have in the diagnosis of a patient in the endemic disease. And finally, the 2 minutes that I have, I would like to highlight on the paper what can happen in, in, in HIV. We know that in the HIV, one of the gaps that we have is that the people who live with HIV know their status. 81% of them know. So we have an important percentage that still don't know that they have it, so that we can get to 90 and 95%. The case of Colombia, for example, we are talking about a prevalence of 180,000 people, and only 130,000 know. So 50,000 people don't even know that they are infected. So here we can see how this occurs not only in the different countries in Latin America, but rather in the case of Colombia, due to differences that could be more than 233% because of a low offer in the tests on the site where they go for the first clinical visit, or doctor's call. They don't have a test right there, so they can be early, and many people can do that, and that way they can be uh, infected, and there we can have an early detection and can have an early intervention. This is not solely in Colombia. This is the recommendation that is done worldwide, where they talk about the interventions to increase HIV testing uptake in global settings. And it's not only for individuals, but actually to diminish the detection of the tradition. We saw it clearly with the SARS-CoV-2, is that we had said that early warning actually reduce the hospitalization. This is the same thing with HIV. They know the diagnosis early, and they start the antiretroviral treatment in early detection. They can reduce all the impacts of this. So that means that the diagnosing strategy is not only to have it as an initiative there, but as a global matter. And in that case, the strategy that's prevailing Colombia does not have that. Here we talk about not only first level strategy, but actually strategy based on the community that enable communities and the people in community leaders so they can have mobile tests. So the key groups that can participate in facilitating the diagnosis, and that way we can diminish the transmission for them. The last year, the mayor's office, we recommended molecular tests, quick molecular test. And many times we have a mistaken one that a quick test is actually our less yield test, and that's not true. That is not true. There are quick tests that actually have the same or even better yield than other tests. At least they have the same. There's some classical tests that we know. So the important thing is that these tests must be applied, and that they do the control and follow up in the adequate process, and so on. And here I want to highlight that here we're talking about quick tests that are being used in primary healthcare and out in the community. And here we have it in Canada, where they do run all these quick tests, and these as well as in the places where clearly they make the recommendation when you act the community, in this case Canada, where you should do it there to have more access to the public. I don't know the different sites where in Colombia we can see there some of the limitations of in these strategies. And finally, I don't want to use too much of my time. The 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 outbreaks of these viruses, and then we have the tests to be able to have earlier ones that we can actually mitigate these infectious diseases. Thank you very much, Dr. Carlos, for your excellent presentation. And definitely you reaffirm what Dr. Marta commented about that transition that we're living towards molecular tests that are now readily available in the community, and they're readily available for healthcare providers that actually do primary healthcare And so there we are actually enjoying the community, the people in the center so that we actually facilitate the diagnosis so that we can have more access to this. And therefore, as you mentioned, for example, to have an impact of reducing the antimicrobiome resistance. So here, I'd like to highlight the community ones of health, the role that they may have to come together to the access of health, primary care, and then we have there, and then we have in the world as to how the community diagnosis have been able to prove it in tuberculosis and malaria in Colombia. We have already some experiences that actually been presented in these venues in the district of Cartagena and in Buenaventura, where the community ones are actually using all these tests. So, Dr. Carla, thank you very much. And then we have it there so that we can give it there to the steps of the ones for the doctor there, Andrea Marciol of Argentina, and Dr. Medina of Colombia, who actually will present to us the Chagas illness in the Colombia case, and in particular in the province of Boyacá. And Dr. Machola is a medical doctor of Med Sans Frontières in Bolivia and actually work in the access of ODNI and so on for those forgotten or orphan illnesses. So we have this for the Chagas one, and then we have there for the UTCA there, and then we have the ones that we have of public health of Juan N. Corpas, and he's the current coordinator in control of these transmitted vectors in the Secretary of Health of Boyacá. So, Dr. Andrea and Dr. Medina, the floor is all yours. Thank you, Mr. Bernal, for the presentation and for the venue that you have to be able to share a bit the experience that we have had with Dr. Manuel Medina of the implementation of an intervention strategy to improve the access to the care of Chagas in Colombia. Meanwhile, I would like to begin to share. You're going to tell me if you can see it. Yes, I believe you can see it there. Yes, we can see it right. Can you see it clearly? Good, great. So thank you very much. If you allow me quickly, I am going to, there we have there the VI and so on, and then we can see people that perhaps don't know what is a DNDI is an international organization. In English, it actually has a clear mandate of researching new tools, therapeutical tools for orphan illnesses, forgotten illnesses, and then also actually do a selection of those orphan illnesses. There are many of them, and here you can see at the bottom the 10 illnesses that currently they have in their portfolio. DNDI was created in 2003 by several public and private institutions and with a permanent accompaniment of the WHO. And here you can see on the left all the organizations that are founding organizations. They're all research institutes and they're public ones throughout the world, and they have this great presence and accompaniment of Medicine Frontiers so far. And then we're doing, and then we have there in the market, they have 9 treatments that are accessible and they're directed to illnesses, and then in the country of the ones that we did, and then we have an average, and then we have there the institutions that we share um, research processes and more than 80 partners in there, and they come from the health platforms of public health platforms. And now getting that to the nitty gritty, you were saying that perhaps because of the justification as to why is it necessary to have a special healthcare model for Chagas. Well, in reality, one begins to think of a specific model for Chagas. Well, Chagas is an illness that is a forgotten illness. Yes, we can see them there in the statistics globally, less than 10% of the patients that estimate to have there globally know that they have the Chagas. and less than 1% of those have been treated with treatments that are specific for their anti-parasites. So, in the epidemiological profile in Colombia, also we have more or less share these figures that are generated regionally. So, at any rate, the Chagas illness has certain conditioning factors or characteristics that make it an illness that is not only forgotten, but actually a silent disease because as a silent and chronic evolution, and this makes it even more difficult for the health services to actually think of it and find the respective patients. We have multiple barriers, multidimensional, and that at some point in time do it with the access so that it be more difficult. And the issue of care and the models must be adapted to all these circumstances that are being seen in different contexts. And here we have some examples of problems or obstacles that we see generically, and they actually are associated with the systemic barriers that have to do with problems that are regulatory problems to actually have access to the medication, to the diagnosis, and then there are also supply problems. The health system doesn't do a routine testing out there, doesn't seek actively the patients, and their structural barriers that actually have to do with what we know poverty, rural living, unemployment, or informal employment. And then also we have in terms of clinical barriers that they're more or less across the board in our region, where sometimes there are some guides but are not updated. And today we have like certain medications that have limitations in their safety, and we have problems in as far as measuring the curing of the illness as well as the complex diagnosis of currently. And at the same time, this is accompanied by all the psychosocial barriers that actually are very important to recognize to be able to improve the access of the people to care. So DNDI started to work in the creation of a strategy that would enable it to identify jointly in the with the partners, in this case at the Colombia level, with all the players and authorities and territorial ones to define an intervention area, a working model in the network. And what we actually saw is an approach that we had a pilot one where we actually and that we have there where we can actually show the feasibility of the implementation of the model, the successes and the lessons learned. And really, it is a good test that we began with a very low investment, but if the results are successful, after that we can replicate, expand, and upscale the model, and that way we can guarantee from the beginning a sustainability since it implements it within the framework of the health system of the country. As you can see, we can actually call it a 4D model, and these are the four steps that we have to design in the strategy we started with. Step one, which is a diagnosis phase, that mainly what one would highlight there is a seminar of barriers where jointly and in a collective way we identify the barriers that there are in the healthcare for the Chagas illness. And as of those barriers, then we propose solutions with which we would pass to step one, where we have a design phase of the model based on the knowledge of the barriers and with solutions that actually point to eliminate those barriers. And here We speak of the models and the attention path through the leadership of the health systems of the ministries, the programs, the vector controls, the Chagas ones. Then we also design a monitoring and assessment, and then we have a plan that actually accompanies it, which is a plan of focus on information, education, and communications, IEC, and that we have in the health system and in the community. Step three is mainly focused on implementing that uh, that care path where you have the pilot plan and we have that access accompanied by an information, education, and training plan where that's the development where we strengthen the capabilities locally to guarantee sustainability of it. And here we're speaking of capabilities in as far as human resources, capabilities in as far as lab networks, and the fourth step is the demonstration of impact, where we analyze the data in a pre and post intervention and we generate the lessons learned, and where we visualize and share the experiences. Here you can see the four steps of the model 4D, and it is published in the Pan American Health, the PAHO magazine. These are the steps actually seen in the diagnosing phase, the initial one, where we actually highlight the access seminar in a collective way. Then we have the design. In step two or stage two, mainly in Colombia, we have seen and focused on the support of the design and the care aligned under the priorities of the Ministry of Health and also the recommendation of the PAHO and the World Health Organization. So, in the development phase, we highlight the training of the health care personnel, the strengthening of the records recording, and also the need to have with the trainer seeing a scheme for the future sustainment of the interventions, as well as the accompaniment of the technical support in the update of guidelines, manuals, and uh, and protocols. And now the demonstration of the impact, I'm not going to spend much time there. My colleague is going to mention it in his specific clinical case of Boyacá, and they have been really very successful where we develop 4 or 5 indicators that are key in the monitoring process and assessment process. And we can see how we have actually made the changes between a baseline before the intervention and then a year in, or 2 years in, or 3 years in of the pilot plan. And in our case, the data that we have that we're going to have by Dr. Manuel, we're going to have in Boyacá, we saw them after 2 years of implementation of the project. As you can see, we have had an increase, an exponential ones of the ones screened, of the ones that are confirmed, the days, the waiting days that we have to confirm the treatment and have reduced, and to initiate the treatment has also been reduced. As you can see, we are in the last slide, and these are the landmarks in Colombia that enable us to work in what was the identification of barriers, and a second landmark in the design to accompany the National Institute of Health in the design of the new algorithm of the implementation. It was the implementation in the 5 pilot plants in the greatest area of the um, disease being present, and actually is very, very successful, and the perspective that are going to come accompanied with the replication of the model and the simplification that actually points to doing far more effective in terms of implementing the primary healthcare stage and actually can expand and to increase the integral route of integral care. This all being accompanied by the implementation of the EDME Plus, so eliminated in the children, not only of the Chagas disease, but actually accompanied with the other three events that we participated, HIV and ETBs. Well, thank you very much. And now I'd like to hand over the mic to my colleague, Manuel Medina, who will comment and share with you the experience in Boyacá. Thank you very much. Good afternoon to all. Are you hearing me?
Buenas
Yes,
tardes a
I
todos.
did.
Bueno, gracias. Voy a rápidamente pues dar continuidad a la presentación.
I'm going to continue the presentation. Next, please.
Bueno, dentro de
Right.
la
So
experiencia
here,
del
within the
ya les
experience that
había
we had in the
ya les
province of
había
Boyacá,
comentado,
at the
que
pilot
fue
plant
una
that we had
reducción
already
de
shared,
acceso al
given
tratamiento, nosotros
the
empezamos a
reduction of
analizar
access to the treatment, we actually
cuáles las
saw
acciones de
the
hacer
need to
con
articulate
diferentes
this
acciones a nivel
collectively
nacional, con
so
unas
that it
acciones
developed nationally with
puntuales
some of
en
the
atención a
individual
individuos
actions that
pacientes
actually done at the
identificando
patient
algunas
level
de las
and identifying
puntos
some
más
of the
importantes
elements, the most
que
important
pretendían pues
elements
eliminar esta
that actually
reducción. Para
pretended
el
to
caso del
eliminate
piloto,
this right. For the case of the pilot
se
program,
escogió el municipio de Soacha, que es el
we
municipio más
chose the
representativo de
municipality of
Boyacá,
Suata, which
que
is
tenía
the
un
north of the
una
province of
alta
Boyacá,
tasa de diagnóstico
and
de
had an
casos
important demand of cases of pregnant women and chronic
que se
cases. It's
estableció
an
una serie de
endemic
barreras en la
municipality,
implementación y
and we
autorización de
had
estos
a study
procedimientos
of
y
barriers and
además
all
de
the
una ventaja muy
procedures. And
importante relacionada con
we
los
had a
índices
very important
regionales de segundo
case. There
nivel.
was a
Esto
regional
para
center,
nosotros fue un poco
second level,
difícil
and it
dado
actually
que es el
concentrate
municipio que está
7 municipalities and the
certificado
ones
a
that are
nivel nacional.
certified
Aquí hay
in
un
terms of
modelo
the
de atención
transmission. Here we have a model
de
and an
evidencia que
important
son
model that actually
presencia de
evidences
municipios
that we have
directamente
5 municipalities
atendidos al hospital,
directly associated to the hospital
también
from the
financiero, y tres
standpoint of
municipios que son eh,
administrative and
independientes,
financially. There's some three
cada uno siendo
municipalities that
un
is
servicio más
independent that actually gave
independiente.
us their
Como se
more
mencionaba,
chase
nuestro
and the
primer
diagnosis.
paso
As we mentioned, the
se
first
cuenta
step
ayer de actualización en el
that
año
we had there
2016.
in that
Se
workshop of
tuvo
updating in
integrado todos los
2017,
actores
where
de
we
la
integrated
población,
all the
la
players,
comunidad también,
the
para que
community as
puedan
well,
usar
so
los
that we
servicios
actually can actually
todo
do
lo
the
relacionado con la enfermedad
dissemination of
y
everything has
hacer
to
un
do with the
acompañamiento
uh,
relacionado con la enfermedad.
Chagas illness and everything
Participamos
associated with the illness. We participated with the
del municipio de
public and
Soacha,
private network
del municipio de
of the
Leal,
municipality of Soata and the
básicamente se
neighboring
quería
ones, and it was actually
recorrer un
oriented
recorrido
here.
de
I'm
tiempo
going to cut off
dirigidos
some
a
of the
que
slides,
con una sola
considering the time,
llamada
that here that
fueran
with one
apoyando
sample, we would do the diagnosis from the outpatient
actuación de la
uh,
Oficina de Salud Pública del municipio de Soacha,
visit, and then we
se
have
generaba
to the
una
ones from the municipality
logística
for each one
adecuada
of the cases. And
para
from
los
there,
tratamientos
we
respectivos
would carry out the
los
respective
tratamientos de cada
treatments.
uno de los
And then we
municipios
can see
los
the
pasos a
different
paso. Aquí
municipalities
ya
that came
tenemos
from their patients. And
los
here
resultados
we are now
de la
sharing the
actualización
results
de la implementación del piloto, en donde
after the
se logró
implementation of the pilot
satisfacer
program.
al diagnóstico en
2,000
32
people
meses
had
y
diagnosis in 32 meses, and we had
para
an
terminar
increase
en
of
Chagas, eran
220% of Chagas
55%
illness,
los
and we
detectados,
integrated
el número de
with
casos positivos detectados para la enfermedad de Chagas en el
100
municipio
percent in the cases in the municipalities that were detected, and we reduced the time from the medical
de los
uh,
pacientes y del
order until
69% del
the
diagnóstico
treatment, and
y se
63% of
Esto
the
nos dio
diagnosis
una
to the treatment. So
claridad
this
de que
gave us
la
the
estrategia
vision that
de la atención
the
integral
route of integral care of the Chagas illness
tenía resultados positivos
was
y nos
having
llevó también a
positive
la
results and
estrategia
actually led us to
en
upscaling
este
it to
caso
our
en
municipality.
Tiraroa.
That is the case in
También la
Munis-
implementación de algunas
Muniquira
barreras
and Guerrero. Here we
en algunos
identified
casos
some barriers, and
la
in some
barrera
cases,
grande era
the
contar
greatest
con los
barrier was
recursos
actually not having with the
suficientes para el
necessary team
tratamiento
to do the
y
diagnosis and to do the treatment.
a
So
través
that
del departamento
BNDI and through the
estos equipos
provincial government, we bought those
establecer la
equipment
capacidad
and we
instalada para
strengthened
cada
the
uno de estos casos.
installed
Igualmente
base
se
for these
identificaron otras barreras para
capabilities.
las cuales
And
había
then we
que
eliminated other
trabajar
barriers where
y
we
esto es
acted
lo
in
hemos
each
hecho
one
con
of
el
them.
piloto.
And I think that's
Aquí
also
abajo
one of the
podemos ya ver
successes of the
los
project. Here we can
algoritmos
see in the map,
diagnósticos de acceso
we can see the diagnosis network and access in the province of Boyacá before 2017, the municipality of Tunjan and Bogotá. Now the network is strengthened in each one of the municipalities that are colored. So here I want to mention specifically the results of the pilot programs of the upscaling, excuse me, in the valley of the Tensa River. There we have for general population of the year 2018 to 2019 to 210 to the pilot. So 2019, we went there with an increase of 347%. So there we had the baseline of 159 in 2018 to 2019 to 252 pregnant women with an increase of 60% in respect of the baseline. In spite of the limitations during the pandemic, the data suggests a strengthening in the screening of pregnant women in respect of the two periods that we analyzed, which indicates a very good result in as far as the treatment. We must present here all the municipality of the pilot place, as well as where we upscaled the protocol. And then we can see that the diagnosis that we did during the 2020, 78, 915, 89, and 191. And then I want to show you on the right the treatment. So then we had there, it is clearly it's not 100%, but in certain cases, that's one of the aspects that enables there. And we have the ones that we have to strengthen, but at the same time, it's clearly higher than the national levels that were expressed, which is 1% of the population that actually has treatment of the Chagas illness. And here we need to highlight in 2020 when we developed the pandemic. And also to close, I want to also um, share with you, socialize. There's a project that we have the Native American community, the UWA community, where we have been screening more than 4,500 members of this Native American tribe. And then what we can see here on the screen, and especially with academia and the national organization, international organizations, the DNI and DNDI, there we have there with the Chagras, the diagnosis that we have involved in a very special protocol of treatment. They all go to the same place where they receive the treatment with special support from the care providers and the insurance companies, so that we, for us, has been a very important experience and worthy of being copied in many other sites. Then we have administrative challenges where we can reduce the times to actually have care. We can promote general medicine and treatment and pharmacosurveillance and the development of technologies to simplify and diagnose it, just like Dr. Alvarez was mentioned with this quick test where we have these advanced tests that actually are very important, that in the last meeting of the platform were actually presented and they have a very good perspective. So I want to excuse of speaking so fastly given the time, and I'm much obliged. And so actually keep in mind all the territories for to socialize all these experiences directly. Thank you very much, Andrea, Manuel. Thank you very much for this very nice illustration that actually helps us to visualize how, as a systemic approach, where all the players actually take part, where the community gets involved, where you have elements of strengthening the competencies of the infrastructure, equipment, technology, human resources, and health through training and through guidelines, practices, supporting decisions. Actually, you can have decision makers have a successful intervention in diagnosing and treating a community. Thank you very much for this experience that is so interesting. And I wish to hand over the mic lastly to Dr. Jose Alejandro Mojica, who is a pediatrician of the Military University and of the Autonomous University of Mexico, Magister in HIV in Rey Juan Carlos Almagro, specialist in clinical epidemiology, and currently he's actually working with the transmissible diseases of the Ministry of Health of the Social Protection Colombia, Sur, and the country clinic in Bogota, aside from being a professor of a university professor, and he was a member of the Louis Pasteur Institute. He will speak of the current challenges of administration in Colombia. So, Mr. Jose Alejandro, welcome. Well, thank you very much. I have inconveniences with my presentation because it was not the one that I downloaded. You would prefer that we projected? Yes, if you have them there, I can find it, but I had it here at hand. But Juliet or Janet, actually, if you could actually have it there to put it there, I think that something happened. I don't know, something happened in the computer. If you give me 2 minutes, I'll try to have it to the planes. It gives him more independence. I think it would take less, but I do have inconveniences to place it. Give me a minute. I think that I have it. So thank you very much for the invitation, for keeping in mind. Thank you very much in these 12 minutes that I have. I want to tell you what we're doing in Colombia in terms of vaccination and the challenges that we have right now to be up to date as a result of the pandemic. I don't know if actually, can you see it?
La pantalla.
We're seeing your screen. Okay, here we have it.
La
Right.
vemos.
Yes, yes, we can see it. Please go ahead. Right. So we're going to see the current status in the vaccinations scheme in Colombia, the plans that we have, and the commitments that we have internationally. And aside from that, we will see the current status and the challenges that we have to face. Here we have this plan, Public Health 2022-2031 for Colombia by 2031. Basically, we have coverage over and beyond 95%. But aside from that, we actually fulfill the international commitments, which is to keep what it means the eradication of polio, the elimination of measles, and also the blood and control of the other diseases. But aside from that, to have the vaccination without barriers. When we have open front the borders, but the people who get to Colombia, there's are subject to the same rights to vaccinations as national citizens do. But aside from that, the way that we do it is actually to have enough biologicals and not to have the vaccines that should be introduced within the scheme. The logistics part, the capabilities, that everything that it means, the materials, not only in public health, but everything that it means for the network to be able to have vaccinations. We have 21 biologicals for 29 illnesses, and although I have the time to mention one by one, but I want to have there the immunoglobulins. That means that if we have some rabies attack, so a diphtheria or something that we have right now, so that we have a great threat, but also we have for hepatitis B and for rabies. And there's, look, so this is the program. This is this scheme, the scheme, the vaccination scheme. So basically, what we have is vaccinating children, and we have done so through the collective memory. But parents know that they have to take children 8 times before they're 5 years old. Newly born, 2 months, 4 months, 6 months, 7 months, a year, 18 months, and 5 years. Independent that they don't know what the vaccine is, they know that they have to take their babies for a vaccination. That people just know it automatically. I'm going by number five of vaccination. I'm missing three. And they know that the vaccines are actually dedicated to children's schemes, the two, 4, 6, 7 months, 1 year, 18 months, and 5 years. But now look here, by 9 years, we actually vaccinate women for HPV, and then we have for women the cases of diphtheria. They have not been uh, threatened with those vaccinations, but pregnant women receive three vaccines: influenza since 2005, the vaccine at the 14th week of gestation, the TDP, which is a tosferine, a whooping cough, and now they receive COVID in 12-week adults. They give it to 60 years and receive influenza. So what you see here at the bottom here is the vaccine in children where they're not up to date with their vaccines. So you have a child with 22 years who comes there and doesn't have any vaccines, then you need to come up to date and so on. This is the profile of how we have vaccinated people in Colombia in the past 10 years, last decade. So we can see that we were doing really well. Above 95 is good or acceptable. We had some coverage that were acceptable for the viruses, for the years, for the reinforcements that we had. And then we can see there that we have to improve. But if you see for pentavalent, that actually you see with what is red in there, excuse me, blue, and the triple viral, which is basically red, and the reinforcement that you see in green. But look, that in the past 2 years, as a result of the pandemic, look at the coverage just dropped. So definitively, the great challenge that we had here around here, this is how we got here to 2021. We actually came here to an average of 90%. In 2020, they come here, and in 2021, actually they had 86% in all the biologics. Yes, and we have by August of 2022, we have 57% in PCG, 56% in pentavalent and triple viral. So we should go at six, we should be at 66. So we are below what we expect. And as we're doing it, That is how we have the coverage at this time. So here you can observe that. And here's some of the deputy challenges we can see 58%, and we should be 56. We should have um, chicken pox and measles here by December. So we actually get to these coverages, and we're going to have an average of 80 or 56 or 57, and then we're going to have triple viral to 81%, and then we're going to have the reinforcement, and then we're going to have these indicators. And this to just comment how we can see this great challenge in terms of coverage in Colombia. Look at this one. These are the coverages of TDP, which is whooping cough, and this is the primary strategy for all these babies by vaccinating the pregnant woman. And in Colombia, we do in 2012, 2013. And here, actually, we should do it at this moment. And although this is at the coverage, in July, it should be 57, and we're at 39%. It means that only one third of women have received their vaccine for whooping cough, added to coverages that are desirable, and especially here for this year, we have great challenge with whooping cough because now we have whooping cough outbreaks, and now we have a challenge because these are all the present cases of mumps in children below 5 years. And now we have the viral circulation. This morning we had an event in Bogota in the National Health Institute, and where I produced here, what is the trend of the virus in Colombia? And here we have two epidemiological peaks. One peak is in May or June, and another one where we are there is actually goes to December. And look of all the viruses that circulate, influenza is the one that is preventable, like COVID. But important, this is the group of people that are selected to be vaccinated: children, 2 years, pregnant women, the ones that are more than 60, chronic disease, and so on, and also human talent and health. But look, this is the coverage right now for influenza. 1 of 10 children has received one doses of influenza, 9 of them. But the most important, there is a second dosage. The second dosage is the one that provides the individual um, coverage, the efficacy. Not less than 50% have actually received the second doses, and in the year they receive one, they're at 7 out of 10 have received that. But look here, the pregnant women, 75% of them, half of the human talent have received the influenza vaccine. And that's what we have last year. They were actually very reluctant to get vaccinated. And here you can see the most uh, sort of interesting: four every 10 uh, elderly have received the vaccine, and they're the ones who have the greatest possibility of being affected. And so the same thing is with the risk population. That's the influenza map in Colombia, where it draws the attention that in red to the rest, to half of the country, in the elderly and people with risk, and then the second dosage among children, which are the groups that we have to intervene. This is COVID, where you can see that 84% have received one dosage. That's the national vaccine plan. 71% has received a scheme of two, but the reinforcement, the first reinforcement, only 42% have received in the elderly, and we have received the three schemes. And the fourth, you're going to see here that the dosage of 30% have actually received the second reinforcement. So it means that we have a huge amount of challenges to vaccinate in respect of COVID. And now we're going to see the children, 66% of them have theirs. I mean, not even one, 46% actually have received of all the country that since October of last year were vaccinated children with Sinovac, and actually have they received the children of 12 years and older. You're going to see there because of their own. Two have received two doses. Only 26% have actually have received the reinforcement 3 months there. Have they actually placed the reinforcement, which is vaccine of RMA, a messenger of after 12 years. This is the map in Colombia. We'd like to have everything green, but although concentrated in the Andean regions, we have yellow and green, but all the outbreaks, the most remote areas in Colombia, they actually are all red, and they're actually lacking the vaccination of COVID. And look, the first reinforcement we have there, also in the Amazon state, we have there in Tepinderes and the Andean area. So this is the kind of snapshot of Colombia, the national plan of the permanent of the COVID. But now we have some international commitments. It means to eliminate measles, and we know that polio has been eliminated, and we have to keep there. But we're not going to tell you challenges: yellow fever. We have the elimination of 2026 to eliminate it by the PAHO and the WHO and so on, but we have had some active outbreaks in the Americas. But I'll tell you what we're doing to be up to date with the children and the people that actually live in this risk area so that they can be free of yellow fever. In HPV, we have it actually very serious in Colombia. What happened there, like in Carmen de Bolivares, is actually very embarrassing because the collective anguish that we had in 2014, and there we have not had any better results. Tetanus, hepatitis A and B by 2030, and actually to overcome meningitis. Now we have a challenge in Brazil because in Brazil by 2017 have had outbreaks and in rubella and in measles, and then we have the coverage in the last 10 years, especially in the first and second doses of what I told you of rubella, chicken pox, and measles. So now we have here not only in Colombia, here in the Americas, we have 30 million of people there to vaccinate. Mexico already did an additional doses to the year and 5 years of measles and rubella, and and, uh, and then we have actually vaccinated 5.6 million, and then we have still a challenge. And the countries in green and yellow, but we want to see it all in green. Why? So that in these 10 years that we had these differences in measles and so on, we have to be up to date. Polio. Look, polio is a great challenge for Colombia, for the world. And then we have the gradual oral polio, and then we have to have coverages over and above 95%. In the last 10 years, we have had coverage above 90%. However, in this surveillance of the public health, for we have actually done it more or less. But look, this is the alert that we actually had 15 days ago in the US of the case of polio of this youngster of 15, of 20 years of age that actually was not vaccinated. In Colombia, we're at the second dose, and we have all children in the first year they received 3 polio doses, and this year we'll put the fourth dose since June. And the idea is to have one doses over the 5 years. And by 2026, we have this plan of eradicating polio, that we don't have a case of wild polio that we don't have since 1991, and to have one derived from the vaccine. Another challenge, yellow fever. I told you that we have in your neighboring countries, Brazil, Bolivia, they have outbreaks in Peru, and here we have in Venezuela at the beginning of the year. So we're starting at the all the children, all the adults under 59 years of age with yellow fevers and migrants and so on that come to the areas where you have the vectors so that we can be up to date for yellow fever in HPV, where you can have here that we have had since 2014. We have this of Carmen de Bolivia. We began to increase in the pandemic, and we have actually increased. And then we started last year, there were two dosages, and then we have in the 9 years, we had in the last year in 39%, and then the second dosage here. And this year we are in 20%, and 30% of hepatitis B. So 2030, we should eliminate hepatitis B. And we know that we started to vaccinate hepatitis B in 1994, universal. And now we have a group of people that actually are doing the prevalence, and they have given us more or less than 27 years. So specifically, in these special groups, HCH, where they have sex men and sexual workers that are injected, and people who live in the streets who actually are putting the vaccine 0, 1, and at the 2 months so that we can put them up to date, and basically we can impact the population. And we're doing this with the World Bank. And lastly, putting ourselves up to date in the meningitis. We have in Colombia, we started in 2012 with PCV10. But look, all the PCV10s that were actually against all the men, they were dementias, and then we did not included the ninth, and then we have there all the requirements for the vaccine. And then we did the change of PCB10 to PCB13 as we had it, and the fourth and 12th month. So this was as of the 1st of June, and then we had the impact. And this is the snapshot in Colombia, and this is my second and last slide where we actually have to eradicate polio with the 4 dosage that we have. The idea is to put 5 by 2026. The campaign of eliminating rubella and measles. Then we have the reinforcement of 5 years and 18 months. We eliminate the hepatitis B, including other groups. We had the other ones there, so it would have been difficult to the pandemic. And the idea is that we fulfill that group that we had there, those 5 groups that we mentioned. And then we have the PCB10 to PCB13. That's where we're replacing the serotypes that are not included in the ones we have in 12 and then we're going to overcome the meningitis, and together we're going to have an additional dosage of influenza and the 18 months, and we're not going to be able to do that this year. And we're doing a pilot program for premature babies with there's 9 centers in Bogota where we have kangaroo babies, and we can improve what is the assurance of the biologic, and we vaccinate with pneumococcus, and then we have the vaccination campaign January, April, July, and October, and we are conditioning the strategies and the vaccine institutional ones, house by house. We have the ones that we have the micropulling, and that's fundamental. So this is the last line to recover coverage. That's a mandatory that people have access to the vaccine so that they have the trust of the family, especially the safety of the family to strengthen the extramural ones with all the allies, the people who are in the streets, the migration phenomena that we're having from neighboring countries to maintain the eradication of poliomyelitis as well as measles, and then we have to have the centers. Now we have 1,000, 2,000 have already COVID integrated the strength of the web system, and also to implement the changes proposed of what we mentioned of the fourth doses of polio, the PCV13, the fourth dosage of Haemophilus, and then to strengthen the technical capability of people in general, and then to promote what it means to vaccination. That's what I had specifically. Can I spend 15 minutes? And my excuses, I know there are a lot of things that I wanted to share, but basically the responses in the panel. Dr. Bernal, it's all you. Jose Alejandro, thank you very much for your presentation. Definitively, we have important challenges in manners of immunoprevention in Colombia to actually care for these threats, the current threats, and the former ones. And of course, we're going to make them more complex because, as you indicate, ever more the immunizations included in the pie are more, so it's a greater number. So this makes it difficult, the access and so on. And sometimes it's introduced. We have uh, vaccines that showed that added to the pandemic, to the research against vaccines and social networks that they were speaking about by Dr. Matter, and the damages that they can do if they're not properly. They have a negative impact in all these coverage. So I, at this time, will actually give a mic to Dr. Gabriel Carrasquilla, who will be the moderator of the panel of the guest speakers. And I invite everyone to turn on your cameras. Dr. Carrasquilla is a medical doctor of public health in Harvard. There's and the secretary of Biomedical and director of the Foundation FIS, and the director of the Research Center in Santa Fe, Bogota. And he's a founder of ACSLU and the vice president of medicine in Colombia and the corresponding member. And then we have of the Venezuelan medical committee and the member of the policies of the WHO. He's been a counselor for the National Program of Cold Sciences in Colombia, and then the Gavi proposal. He's been a university professor. He has actually led research and international projects, and he has more than 100 publications in national and international magazines. It is an honor, Dr. Carrasquilla, to have you with us. And please proceed. I'd like to invite the people to formulate your question through the chat by raising your hand. Thank you very much, Luis Gabriel, for the invitation to this panel that is so interesting, and at least for me, that is very passionate, talking about infectious diseases and all these situations that actually come before having any questions by the members and the panel members or the people here. I'm going to run a brief question to each one of the panelists that within the framework of a very current situation, because we in Colombia, particularly for Colombia, we are at the onset of a reform to the medical or health system of Colombia. And one of the points that the people have insisted the most in the reform of the health system is that we have to reinforce, promote, strengthen primary health care. And I think that we are all in agreement that that has to be done. But one thing is easier said than done. How can it truly be strengthened and to have the strategy, primary strategy in health the Declaration of 1987 we have not passed yet. So we also have to make a differentiation between what is the first level of care, the primary health care, and what is the strategy of healthcare that we have here that has to do there with some elements that the guest speakers have actually mentioned as intersectorial, as appropriate technology. And I'm going to start by this last one, which is the technology. It's a question to Marta Spina because she mentioned something that is tremendously important, and it would be worthwhile that they tell us a bit more in detail how you she mentions in the first capabilities in the first things that they actually which is actually notifications and is very innovative by saying that there have to be other players in the notification, in particular communities, social leaders, media leaders, how to implement that in a system like ours, doctor. And there's a point that was mentioned by Luis Gabriel about the functionality or usefulness of social network in current surveillance and epidemiological checks, and an experience in Mexico that was very beautiful, and that was that the Carlos Slim Foundation, that of course is the Comcel owner, did a follow-up and found in the social networks that they were capable, because of the comments that were made, to declare an epidemic before the surveillance system can detect it. How to make these innovations that are truly an innovation, make them work in a system like ours, right at the beginning of having an important health reform. Let's just say that the reforms that are going to be made to the health system, fortunately, are not in so much detail in the collective strategy ones, or at least the ones that I have seen so far, or in the world has not been like that. So that's important. Why? So that we can continue to innovate. Colombia has very important progress. When I mentioned that there are other information sources, we use them in Colombia. So the risk analysis and the emergency response team actually are being nourished from different sources. The notification that we will have, they simply, it's just a pathway to truth. But there are other ones, and actually we can use the tendency analysis, and we actually use the trend analysis. We actually use them in the health system, and we identified the last outbreak of before COVID-19 in the last peak respiratory epidemic peak. It had a prevalence of H1N1 in Cali in the West, and we identified it with a network of WhatsApp by parent, a TPA, Parent Teachers Association. So then we have there. So as a matter of fact, if you actually could think in a Cartesian plane in which you have in the y-axis a greater level of diagnosis because you have lab tests, preventive test, and so on, and test of antibodies to test molecular test, and we're very certain on the X there, you have the volume of data. With what you have there in this, one, you could have a great volume of data as a social network threads, 10,000 people in Twitter, but very few diagnosis, and even there, know to see the sensitivity of that measure, if it's the same as if you have to have a conglomerate of cases as with PCRs. So under that principle, we actually can done this orthodox of cases of the famous suspicious case, the confirmation. All those orthodoxies are no longer necessary in all events. So we're going to feed ourselves daily with these emergency ones to have all the provinces in this, and then we see multiple sources. And likewise, we are actually remember that we were doing these characterization of what we were doing of the OPV, and we characterized them. And now you don't need them. We have that families of identifiers, and then we have there of the professionals that are independent, that actually they pass on their hands. And it's important because they're not part of the system. They didn't have the information. So it was a matter of lowering these orthodox means and then to affect all these type of notifications. and then we see by part of the community, and then we see the models of the justification of the community. And it turns out everybody has a mobile there. Why community notification? Even in this most remote town, you have a mobile phone. So that was already done. So what we have to have in the mobile there's is apps and mechanisms to give to the system an app that actually can issue news. Like actually have like the notary publics that actually they notify the news, and that's what we have we have the confirmation there, and we do that in the world of surveillance. So that changed, and then we have to do a course, and we're going to do an online course to put everyone of the entire system to how all these systems work and how they work in Colombia, how they're operating and the like, because they're quite sensitive in the world. So this is like a change of paradigms, I think, in the head, right? In what we used to think of how we used to do things. And there are tools, and we have been talking of something that is really very important. Is very quick tests have a very great use in a context. Even one can actually be obvious as the second steps in hospital services. One were to use adequate all the strategy of these diagnoses. So if one knows how to run those algorithms, you actually can save money. But that is a change, I think, a change of paradigm of thinking. And we have to work them from the medical schools, but also like in this type of initiative of groups, this type of new surveillance. I don't know if I answered the question there. I think that there was a second part of the question. Yes, you answered it. Thank you very much. And truly, I've had some very beautiful experiences in Mexico, Brazil, Colombia, Venezuela, of understanding the community based on mobile phones. But actually, your comment brought it to the question to Dr. Alvarez, because Dr. Alvarez, in his second slide, actually had an excuse and said, "But look, here we don't have malaria, so I'm going to ask him of a case of malaria, but it's in respect of the quick test, Dr. Alvarez, and that is if this is a new technology, it is a new technology that we have to exploit, obviously, but you know very well the situation of malaria in quick tests with HRP 2 and 3, which is a deletion and so on. So the quick test doesn't identify it, and that happens mainly, or does happen in plasmodium. So it's that situation that could be non-identified because generally you, who is an infectiologist, would know better than me parasites, viruses, and bacteria. But scientists are smarter than us, so they can avoid these type of things. This type of situations, are they happening in other sorts of detections, and that how would that help us so that in this new stage that is coming for Colombia, very probably, how would we do so that at the first level, these difficulties may be solved if they actually present themselves? Well, I think, thank you very much for the question, Dr. Carrasquilla, and I'll meet you once again. I think the point here, once again, to keep in mind is actually that the tests that have to begin to adapt to the needs that we have in the territories, that's the way to go. And I think what we have are the same tests that actually appear and continue to appear, not only malaria, actually we have, I lost them.
Pasó algo que se quedó paralizado, doctor Álvarez.
¿Me están escuchando?
Otra vez, sí.
Can you hear me now? Yes, yes, we are now. Something broke. We have some problems with the connection. It seemed that the problems that we have in malaria occurs with other illnesses, and we're having breakups.
Puede ser que ocurre que yo de
It could actually occur.
Hola.
Right. Again.
Bueno, decía que
So I was saying,
lo que puede ocurrir con
what could happen with
puede
malaria
ocurrir con otros microorganismos
actually can occur with other microorganisms that regrettably there can be change, given that some of the yields that we can, or the tests that we can do, but that should not work, that we cannot work that way. And that what it implies is that from the standpoint of the innovation, we have to adjust those changes to the true reality of what's happening.
Gracias. También
Thank you,
la
Kay.
doctora Marta Ospina nos
Now, Dr.
hablaba
Bartolo
en otras
Spina
clases para
gave
la
us there
situación de
about the
Chagas,
situation of Chagas
porque sí que podría ser
because
importante
it could be really very
esta,
important.
la
This
nueva vigilancia, como lo llama
the
Marta,
new surveillance, as Martha
utilizando
calls it,
todas estas
using all these
nuevas tecnologías para el
technologies
diagnóstico.
for the
La
diagnosis.
prueba piloto
The test, the pilot
que
test
ustedes realizaron
that you actually
Boyacá,
performed
doctor
in
Medina,
Boyacá, Dr. Medina
mostró
showed
que de verdad, como
that
lo
truly,
anotó la doctora Andrea
as was mentioned
Chagas
by
y
Dr.
muchos
Andrea
otros, pero en
Chagas
particular
and
ella,
many
es
others,
una
but in particular
verdadera
when the
enfermedad
true
desatendida.
illness that is
Cuando uno
forgotten,
mira la
when one
comparación
actually sees the
entre
comparison between
la prueba de
the,
base
the base test
la prueba piloto,
and the
cómo
pilot test,
aumentó
how it
en
increased
1500, en 1400%,
in
y disminuyó
1400 and
el
it
tiempo
diminished
de
the
diagnóstico
time
y el tiempo
in
y
the
el inicio del
diagnosis
tratamiento
and the
en
time
casi
the
un
treatment
80%,
starts,
cosa por el
almost in
estilo.
100%
Eh,
or something the like.
¿Cómo hacer
How
para
to
que estas enfermedad como la enfermedad de Chagas,
make
en los
that these Chagas
departamentos
illnesses in the
de
provinces,
mayor prevalencia en Colombia,
greater prevalence in
Santander,
Colombia,
Arauca,
Santander,
Boyacá, por
Arauca, and
supuesto,
Boyacá, and of course,
para que haya una adecuada
so that we can have an
respuesta
adequate
por parte
response
de
by
quienes corresponden a
those who
promover
actually have to
la
promote
salud, como las
health,
aseguradoras,
like
qué papel
the
están
insurance
jugando en el caso de
providers, what
ustedes,
role are they
y cómo
playing
hacer para
in our
que
case,
de
and how
verdad
to do
hagan una
for us to
promoción y no esperar
truly actually
que
do
el
a
paciente
promotion
llegue
and
con
not
una
for us to wait
cardiopatía o con
and see a
algunos problemas de
cardiopathology or
Chagas. Aquí en
some other
Colombia no hay
Chagas
el
problem.
megacolon,
In
pero
Colombia,
nosotros sí
we
lo
don't have the
tenemos.
megacolon, but we do have the cardiopathy
No sé si
pathologists.
quiere
I don't know if
entrar
you
el
wish
doctor
to
Medina
start
y
with that
termina
with
la
Dr.
doctora Andrea
Medina,
o viceversa.
finish Dr. Andrea, or vice
Bueno,
versa. How do you want
muchas
exactly?
gracias,
Well,
doctor Carrasquilla.
thank you, Dr. Carrasquilla. Well,
Con respecto a la experiencia de Boyacá,
in respect of the
hemos
Boyacá experience
venido desarrollando en
and what
conjunto
we
con
have
el
been
NDI,
developing jointly with
pues hemos identificado
DNDI,
varios factores que
we
son
have actually
determinantes
identified several
para la
factors in
reducción de
our
estas
funding
barreras de acceso al
to
diagnóstico
reduce
temprano.
these
El primero tiene que ver con la
barriers to
información a la
diagnosis. The
comunidad.
first have to
La
do with
gente
information to
tiene
the
que
community.
saber
People
la
must
problemática
know
relacionada con
the
Chagas
problems
y lo que se
associated
está
with Chagas
enfrentando en
and
realidad.
what they have to
Entonces,
tackle
todas
in
estas acciones
reality.
de
So
educación,
all
de
these
conciencia y
actions
de
of
comunicación
education
son
and
realmente
communication, so
relevantes
they are
para
truly relevant
tener una oportunidad para el diagnóstico y
to
para la
have an
recuperación.
opportunity for the
La segunda
diagnosis
parte
and the
tiene que ver
treatment. The
también
second part
con
has to
que
do
todo
with
el personal médico de estas
all the
zonas
medical
epidémicas
personnel in these
tengan dentro
epidemic
de
areas.
su
They actually have
agenda
within their
en su
agenda
cabeza la enfermedad de Chagas, es
the
decir,
Chagas
sepan de
illness,
qué
and
está
so,
hablando.
so they know
Para esto
what
también ha
we're
sido
talking about.
importante todo
And for that, we
el
actually, it's
desarrollo
very,
de un
very
proceso
important for
de
the development of
adherencia
this
y
process
de
of
socialización de
adherence
guías
and
la,
socialization of
la
guides,
enfermedad de Chagas
where
realmente
the
tiene
Chagas illness really
una
has
serie de variantes
a
relacionadas
whole
desde
series of
todos los lados, sus
variations with these type
varias
of
diversas
matters,
formas de transmisión y
given this
presentación de la
diverse
enfermedad.
means of transmission
Entonces, la
and the
capacitación del
manifestation of
personal
the illness.
médico
So the
ha sido
training to the
fundamental. Se
medical
ha pasado
personnel has
de
been
capacitar
fundamental. We've
10 o
actually
20
passed from
personas
training
a
10,
capacitar
20 people to
450
actually train
personas
450
directamente
people
relacionadas con el
directly
municipio
on the municipalities
endémicos y sobre
endemic
todo
one,
con temas relacionados con el inicio del tratamiento. Antes se
especially with the
determinaba
initiation of
verificar que
treatment.
el tratamiento se
Before that, we had
podía
the
formular
treatment
desde el nivel de la
that we needed to
especialización,
formulate it
como
from the
decíamos antes.
specialization and so on.
Una de las
In
cosas
other
más
words, at the
importantes es a
internal
nivel del
specialist.
primer nivel, o sea,
So at the
toda la
first level,
burocracia desde el primer nivel,
on the
se
first
está
level, we can have a
más
doctor there
al
and not
inicio del
send it
tratamiento
there.
se
We can
requiere tomar
start the treatment
cuidados
and have a
acerca
follow up,
en
given the progress that we
los
have had
procedimientos que
and the
hay
needs that we have
en el tratamiento.
in
Y
their
por último,
treatment.
la
And
capacidad
lastly,
instalada.
the
Los territorios deben
installed
tener
base, the actual the
atadas la
capacity in
respuesta
the field.
necesaria
The
para realizar
territories
el
must have the
diagnóstico
response
oportuno y que
capability
las
so we
pruebas
can have a timely
pertinentes lleguen hasta el
diagnosis
Instituto Nacional
before
de
the
Salud,
test
a
actually
nuestras
go to
labs,
the National Institute of Health and go to
laboratorios de
the
salud pública,
provincial
para
lab,
con una
public health, and
respuesta
now with
poder
one sample,
diagnosticar la
we
enfermedad de
actually can
Chagas
diagnose the
directamente en cada uno de los
Chagas illness
territorios,
with one of the
facilitando de esta
territories,
manera el acceso.
making it
Es
easier
una
to
cosa
access.
supremamente
And it's
importante.
something that
Dentro
is
de las barreras
really
más grandes que
extremely
se encontraban
important.
era
And one of the most
precisamente todo el
important
tema de
barriers we
autorizaciones
had there of
y
the
barreras
authorization
administrativas
and
que
administrative barriers,
de alguna manera eran
and somehow
fácilmente
they were
superables.
easily to
Aquí
be
cada uno tiene que
overcome.
hacer lo
Here,
que le toca.
where each one has
Cada
to do
uno,
whatever they have
tanto
to.
el orden
And
nacional
now we have to
como el
have it
orden
the national
regional o
orders
local,
as well as the
como los
provincial
estados
order,
y las
as
empresas
well as the health
relacionadas con el
providers
nivel de
and the
aseguramiento,
ones
tienen unas
associated with the
obligaciones
insurance. They
relacionadas
do
con
have
toda la
some
enfermedad de
commitments
Chagas y con
associated
todas
with
las
the
otras
Chagas illness
enfermedades.
and with all the
Unas,
other
una de las
illnesses.
obligaciones que
And
tienen
now
están
one of the
relacionadas
obligations that we
también
have
con
are
la
associated associated also with the promotion and prevention. So these are one of the factors I want us to keep in mind, and especially in the specificity of each territory to be able to overcome the barriers, which are different in each site. And some of them are across the board and ones that are in each place. So now, Andrea, please. Thank you very much, Manuel. Well, I just wish if you could allow me to summarize on 2 points the contributions and DNDI in this process of simplification, because we're all aligned that when one strengthens the care at the first level, we're going to have a greater capability to reduce the care barriers. But for that, somehow what we have to do is to simplify procedures. In diagnosis, I think that the entire panel spoke of quick tests. So I think that they're actually progressing. The National Institute of Health is progressing in Colombia to assess the yield in serotex as well as serum text, as well as the ones that we have. We accompany a study of validation of all these quick tests in the terrain. So there, we somehow what we have to do is actually to carry out the simplification process in as far as treatment we have in NDI. Um, Not an obligation, but we have the mandate here. And then we have here where we're working in the study that actually we're bringing here in different countries in a study where we actually propose that even though we're investigating there, that actually we're seeing this a bit far more complex. And if we're trying to study the reduction of the time, the treatment. So that is why we're doing a work where we have a clinical trial where we're testing new times, new dosages with which this will permit to simplify the treatment with greater security and with more adherence. And with that one, this is what I wanted to say. I think that Dr. Marta Spina has her hand raised. I don't know if she wants to speak. One very quick question that is very probably for Dr. Medina before we give over the mic before we actually do this to Marta. And now, in which other provinces are you do the Chagas treatment the way you did in Boyacá? Well, the pilot project was actually that's in the four provinces: Arauca, Casanare, Santander, and Boyacá. And now we actually have a pilot municipalities where they validate everything that had to do with the operational side. And we now have some municipalities that have upscaling this one of these provinces. We're pretending to upscale provincially theirs through the province of Norte Santander and Cundinamarca, as was expressed by Dr. Andrea in her presentation. Okay, thank you, Dr. Medina. So, Dr. Mojica, there is a question that I want to broaden. The question is, what is the plan that the minister has in education and communication to improve VPH, HVP, I'm sorry, that is actually laid back. And then what I want to broaden is, and what is the plan? I know that it was formulated by you, but are there any areas that actually worry uh, somewhat the coming into the scheme of vaccinating, or the vaccination for the elderly, like pneumococcus or herpes zoster? Dr. Alvarez, in a recent meeting in the medical academy, was informing with Dr. Perez, or both of them infectologists, that herpes zoster was reducing almost 30% of the elderly of 60s, and that the pain can actually be even higher than cancer. So one is actually, one is a candidate like me, this type of vaccine. When are they going to be able to be in the PAI with vaccines like this? So are these being thought through in broadening the PAI, and not to take that long, because there are studies we have already done that we had a study there that vaccine like Haemophilus and hepatitis B and rotavirus actually came too late into the schematic, years after they were cost effective. I'm going to be very brief because time is up, and Dr. Marta has actually asked for the So I like to remember two things. First of all, to introduce a vaccine, you must keep in mind what the OMS recommends, not the burden that for herpes is actually being raised. And now we have data for pneumococcus, and all the data in the elderly, and we have a backing of the illness. And the other point that we're keeping in mind is the cost-effective study. The cost-effective study, we have had it for children, but you have to do it for the adult. And we're also speaking of pneumococcal and herpes. And then the other was we have the feasibility because the economic side and the budget, we actually made like a request of the possible vaccine we have pending with the new government to actually propose with certain vaccines that must be included. Again, pneumococcal actually have the risk ones, and we include herpes, but actually we miss the other point is to have the vaccine. There's some vaccines there that we have 13, 15 that we're going to have the serotypes that we actually have had the illnesses. And the last point is the political will. It's actually not the international political will because you don't from the region. They all have pneumococcal at risk in the elderly. And then we have Mexico, Costa Rica, Panama, and the South. They all have, and the Southern Code, they have, imagine that we were in that plan and we could actually actually and there's the changing of children. You mentioned the other like for us to adults, but actually the herpes, you have to raise this the community of the process of immunization to bring them everything that we have. But the burden and so on, the money and so on, and that one, the political will, national influence, and the CFP, what Dr. Malta had actually mentioned. But the other thing that you were asking, I'm not the spokesperson of the ministry, is about what are we doing to improve coverage? Well, firstly, actually to position the country. Now everything is COVID, and not everything is COVID. The people are tired of COVID, but the main problem actually has actually gone to the side. So we'll reposition the pie, not only with messages, to social network, to videos, to everything, to what is the permanent vaccination plans, and we actually have it integrated to the COVID, to the vaccination scheme. But now to the clear messages directly to the community, positioning them so that we can communicate the risk, and now we can have the the whooping cough vaccinating the pregnant women, the breastfeeding ages and so on, and we also have yellow fevers in the region. So we're positioning with clear messages, with precise messages, and outside of that, the epidemiological stage, which is fundamental, but also what they were talking about is they were mentioned that the profile of the safety of these vaccines, because now we have to speak there with the anti-vaccines, because people must identify that after potable water, what have impacted the most is vaccine. So to position that the vaccine have great benefit, it has a great contribution, not only to the children, but the entire family. But actually, aside from that, we need actually to have the vaccines here. They have a great safety profile. And thanks to the vaccine, anyone, so the amount of people actually get saved and we avoid a lot of deaths. And we saw that with COVID. So grossly speaking, we're redirecting all of it, improving the communications, making it more sensitive, and to see what are the illnesses that we have. Sort of a rebound of this. So we didn't have diphtheria, we didn't have it for 20 years. Now we have the threat less than 5 years with parotiditis, and then we have whooping cough as a reference here, and so successively. So this is just to say that we have a great challenge. Um, and great work and to make them more sensitive that the illness is just there. Yes, it's a great challenge. Yes, that is a big challenge. Yes, that's it. Thank you. Basically, there's so Dr. Mojica. Thank you. Dr. Marta, please. I won't take long because I remember what I wanted to say. And I want this book of Chagas reforms. There's something that is actually spending, and it's absurd that we mix the operational need in health services with the structure of the payments of certain service provision. The tests must be where they're needed, and they must be done with the people who are close to people. Period. It's actually absurd to think that we have legal service at level two, and then they don't have it in the public health. There's where are the diabetics and why do you use hemoglobin and the Chagas test and echographs that we have for dementia, they actually have to do with the people that are aware they have the people of the Chagas were there in the field. So the message that is in Bogota, I mean, this is just absurd, and that structure of costs that actually confuse the true care paths and service of people. So if something good we need to modify it within the framework of a reform, maybe that actually to put it in the scope of people, the services where they should be.
Muchas gracias, doctora
Thank
Marta.
you
La
very
próxima
much,
pregunta.
Dr. Martha.
Bueno, ahora espero
Carlos,
que me escuchen, espero
I
que
think that actually can hear me. I hope that you can hear me well
la
now.
pregunta que me hacía
For the
el doctor
question that was
Carrasquillo,
posed, Dr. Carrasquillo, I think
que
that
se plantea
the example that was
diagnóstico de
proposed
malaria,
of
especialmente
the
con
malaria
rápidas,
diagnosis with
digan
quick
que las
test
pruebas rápidas se
forces
pueden
us that the quick
automáticamente,
test
pero que nos falta
actually are very
actualizar las
useful ones that
analíticas
we
para
actually
que
have to
puedan
do with the speed that we have to
identificar
do
los
there.
microorganismos. Y en este
And
sentido
then we
es
have,
importante
in a
tener la
sense,
vigilancia
to
adecuada
actually
para
have
que esa
the
revisión
surveillance there so that
rápida
we can have there.
siga siendo efectivo. En ese sentido, es claro que
And then we have there,
es una buena alternativa cuando hay
we have a good
una prevalencia por
alternative.
más del 10% se desaconseja o la presencia de lesión por más del 10%, pero también hay alternativas válidas como
And then we have valid
el
ones.
uso de la deshidrogenasa láctica del parásito.
And then we have of the parasite.
No
So
solo para
just to
parásitos, sino para
summarize,
otros
not
microorganismos
only ones that we have there,
patógenos,
and then
también
we have,
tienen que ir actualizando acorde a la
and they will
epidemiología
have to be
y a la
updated.
importancia de mantener la vigilancia.
Muchas gracias, doctor Álvarez. Doctor Luis
Thank you very
Gabriel,
much, Dr.
el tiempo se
Lawrence.
nos ha terminado y
I
le
think the
toca
time has been up, so you have
cerrar
to
sin antes pues,
be
agradecer
finished
a todos los
and then to
conferencistas
verify
desde
there.
Bélgica, el doctor Medina, la doctora Andrea, el doctor Álvarez y
And
el equipo de
then we have
Bogotá
there
por
Dr.
su
Andrea and Alvarez
participación.
because of their participation.
Adelante, Luis Gabriel.
Thank you very much, Luis Gabriel. Thank you very much, Dr. Gabriel, and to all guest speakers, really, truly, thank you very much. You've actually left a knowledge of implementation tactically that is immense, applicable to primary health care. And I think that we also are lacking time to discuss all these strategies. Like, as I was thinking, these issues of the countries that actually have been incorporating these incentives, economic incentives, even to increase the vaccination at the different ages. But anyway, we don't have any more time. This webinar is going to be launched in the Salud Derecho platform, where you can see where the assistants can actually register, and you can see copies in the chat. The website www.saludderecho, and then you can there's primary healthcare models, and as you can see in the name and their guest speaker, and Gabriel has actually mentioned in this incredible way this panel precisely to give relevance as to which way the innovation in primary healthcare is actually this idea that we had a primary care, and there we have that no one has anything. It's not now of this historic moment, and we have to take advantage of how technology and the trends in public health can actually come and rescue the primary care to assure sustainability in health care and also to have better health result. We will be informing you about our next webinar in October, not before that, to thank not only the entire technical team of the World Bank and the PCA, Janet Bonilla, Juliet Rodriguez, Juan Carlos Rodriguez, and our colleagues Manuela Villar and Oscar Bernal of PHC and World Bank for their incredible backing for this. A good night to all of you. Thank you very much to all of you.
Bueno,
Good
muchas
night.
gracias. Hasta
Thank
luego.
you very much. Good night. Bye bye.